Thanks, thanks Peter, thanks Bo, Andrew and Anne for inviting me back, and my colleague Gareth to this third hands-on workshop. It's great to be here. I've been on holiday here with my family for the last week in Cyprus, and I can thoroughly recommend it as an excellent holiday destination as well. So how to make sense of all this? Well, I kind of wish that I could, because if I could give you the answer in the next 15 minutes, we could all go out and enjoy the sunshine, but of course that's not possible. But some thoughts based upon what I thought before I heard the talks this morning, and some of the thoughts that I've had listening to the experts and the discussion. Now, how do we get this to go down? Page down? Okay, thank you. So I'll start off by saying that I have no financial disclosures. So we've had some excellent talks and some really stimulating discussion today, covering pretty much every form of treatment for varicose veins. But of course, making sense of the evidence, and perhaps the lack of evidence, because there is quite a lot of lack of evidence, even for treating what we would say is fairly straightforward and common or garden things, is challenging. So just to frame some key questions perhaps, and I'm sorry if this comes from a very UK perspective, and some perhaps of what I'm going to say will not be relevant to people from the other 37 countries represented in the audience. So which people should be referred for specialist referral? At what point in their disease progression should that happen, and to whom should they be referred? What sort of person should be treating these kind of patients? Which treatment should they have? Again, when? Who should be doing the treatment, and where should it happen? Should it be in a hospital, clinic, in primary care, general practice? Who should pay for the treatment? Should it be the government? Should it be private healthcare insurers? Or should it be the individuals? And related to that, how much would we expect our patients to pay for the treatment we offer them? Crucial, because we all accept that this is a lifelong chronic disease, not an acute event. What sort of follow-up is required? And surprising, in many of these meetings, relatively little attention is paid to follow-up when we're dealing with a lifelong chronic condition. And then how do we recognize and measure success, or indeed failure? Is it reflux? Is it recanalization? Is it plethysmography? Is it health-related quality of life? And along with that, we need some better standardized reporting standards so we can compare our experiences. And of course, we need to decide what further studies are required. And the big issue around the endovenous revolution, and it's the same with the arterial work, and I do a lot of arterial work as well as veins, is the question of durability. Yes, there are some big advantages up front to endovascular treatment, but will we pay for it in the long run by a lack of durability? So I took over as the president of the Venous Forum in the UK in December, at a time when austerity measures were biting hard and the National Health Service was looking to save money, about 20% of its budget. So we spend about £120 billion a year on healthcare, and they wanted to knock 20 to 25 billion off the budget. So varicose veins seemed like a fairly easy target, and as my colleague Gareth said, right across the country this rationing was brought in that you can't treat varicose veins in the health service. And of course this upset a lot of people, patients groups, doctors, surgeons. And so one of the things we tasked ourselves in the Venous Forum was to try and make some recommendations to government, to colleagues, about who should be referred for treatment and what sort of treatment they should have. And one of the things that we aimed to do was to offer an evidence-based expert view as to how resources should be made available for the treatment of chronic venous insufficiency, so that these resources could be used in the most clinically and cost-effective way. And the powerful truth is that this is a very common condition, and it's getting more common. We know that there are multiple reasons why people would seek treatment for venous disease, from cosmetic veins through to ulcers, but we know that all of these people have a very significant reduction in health-related quality of life as a result of their disease. And this places a big socio-economic burden upon our respective countries, whether you're in the United States or whether you're in India or the UK. And to implement non-evidence-based rationing is simply unacceptable. So our aim was to make sure that all UK citizens, indeed citizens of the world, should have access, fair and equal access to evidence-based treatment for venous disease. So high ambition. So we made some points to the government and others about the treatment of CVI, One, treatment is without doubt highly clinically and highly cost effective, and it scores very well against a whole range of other treatments that we wouldn't think twice about offering, such as some cancer treatments, such as some arterial surgery, laparoscopic cholecystectomy. It's a long list. Secondly, we now have a wide range of effective treatments that can suit all patients, and you've heard about that this morning. Thirdly, the endovenous treatment is probably the preferred treatment for most, but not all patients, so there is still a role for surgery, as we've heard this morning. And it's still a rapidly developing field, and further research and evaluation is important, and it's important that this should be sponsored by government and not necessarily entirely by those who are motivated by commercial interest. So what about recommendations for, if you like, uncomplicated varicose veins, C1 to C23? Well, C1's easy, it's cosmetic, and people should pay their own way, and they'll have sclerotherapy. So that wasn't really an issue. The big question is the C2, C3. Now, we take the view that these people have disease. Okay, they may not like the appearance of their legs, but it's not like not liking the shape of your nose, for example. It is not primarily a cosmetic problem. It is a well-constructed disease. And these people should have the benefit of specialist referral, investigation and treatment if they have troublesome symptoms that are not responding to conservative therapy and primary care. And the recommendations, I think, for referral and specialist treatment become even more compelling when we deal with the 10% of the population. And in the UK, we know that about 1 in 10 people in the population have C4 or worse disease. We know that this greatly increases the risk of ulcer disease. We know that withholding treatment for C4 will increase the risk of ulcer disease, and this will undoubtedly lead to avoidable suffering and cost further down the line, because we all know the treatment of chronic venous ulcer, once well established, is extremely expensive and very unpleasant for the patients. So we argue that all patients with C4 to 6 disease should be referred for specialist assessment, investigation and treatment. And we make the point that any person with a wound below the knee that is not showing good signs of healing at 2 weeks should be referred urgently, because it's almost certain that such a patient will have an underlying pathology, arterial, venous or whatever, that needs specialist investigation and treatment. And we like to think that this and other arguments that were put forward led to the government to maybe rethink their position. And in the UK we have a body called NICE. I have to say it sometimes it's anything but nice, but it stands for the National Institute of Clinical and Health and Clinical Excellence, and if you like, it polices treatments. And so they decided to commission a guideline development group, and I've been a member of that guideline development group together with surgeons, physicians, nurses, a very wide range of people involved in venous disease. And we've been meeting over the last year or so to try and develop some UK-based guidelines for the treatment of these patients, and we hope that it will be published in the middle of next year. The other thing that's happened quite recently is that, as Gareth, my colleague, said, NICE have looked for the 3rd time at foam sclerotherapy, and up until now, foam sclerotherapy has been under what they call special measures because of concerns about safety, mainly around stroke. But I'm pleased to say that, such as the evidence base behind it as a treatment option now, that they are very likely to lift those specialist measures, which will make quite a big difference in the UK, as will the fact that, as Gareth said, we now have a license for one product, Fibrovane, which is STS, for use as a foam in the UK. So I think that will open up the opportunities for foam for more people than has been the case. So in conclusion, chronic venous insufficiency is a very common condition that's increasing in incidence. There is a growing global demand for treatment for patients and people to have their veins treated. In fact, I was talking to a colleague just a while ago, Peter, who works in Singapore, and he was saying how more and more people are coming forward to have veins treated. We have a better supply. Our supply is, we have more supply and we have better quality supply, so the supply and demand is in balance, and we have a much better offer for our patients now than we did maybe 10 or 15 years ago. So as venous specialists, we should be relaxed. We are future-proofed, as the business people say. So most people with symptomatic C2 plus disease, and I would say all people with C4 plus disease, require referral investigation and intervention by a specialist. That may be a surgeon, could be a physician, an interventionist. That will vary from place to place. I think probably what is clear, that properly performed by people who are properly trained, and I'm sure that's the motivation for many of you to come here, to see experts give you their tips and tricks, that surgery, laser, radiofrequency, steam and foam, in addition to best medical care, and we shouldn't forget that, compression, weight loss, improving general health, venoactive drugs maybe in some patients, are probably all just about equally clinically effective. But as we say in the UK, it's horses for courses, and many, if not most specialists, will probably use a combination of treatments in their practice. This will partially be based on the evidence, but it will be based on patient preferences, the availability of local resources, and of course reimbursement. And we've talked already about how much money is available for treatment. And in the emerging world, developing emerging economies, there's likely to be less money available per patient per treatment than in somewhere like the United States, and we have to recognise that. In terms of cost effective, all of the treatments are likely to be cost effective, and saying that one is more cost effective than the other, that may be quite difficult at the moment, although, as you've seen already, the cost of foam is substantially less than the other alternatives. So I think it's a very exciting time. I don't think we can draw a final answer, a final conclusion at the moment. More work has been done. But I hope that's been useful in summarising some of the thoughts from our discussion, and I hope you enjoy the next few days. Thank you.